I want to do a couple of housekeeping things on the class first before I get started. I have everybody's first paper, a couple of people's second paper, one person's first paper. On the other ones, that end date, the due date, I just really need them by the time you go back for your strategy class, so that I can get them graded and get your grade turned in. So if you're going to be a few days late on your final paper, you don't need to contact me and tell me or contact me for an extension. However, if you're not going to get that paper in by the time your strategy class ends, please send me an email and tell me so I can give you an incomplete in the class and not hold up all the grades because I don't know what's happening with you. So, but you don't need an extension, but I'll need like 24 hours to get your papers graded and get your grade in. Hopefully, most of you will meet that deadline so that I'm not staying up all night because everybody turned them in on the very final day on that. When I get back, I'm going to put together for you a database, an Excel spreadsheet of the physician executive recruiters. In healthcare, anything above a manager level, they use executive recruiters for it because healthcare is such a technical industry that they need somebody with the expertise to screen them and make sure that you have the skill sets. So the executive recruiters will work with you with your resume and that type of thing and help you get a job. So I'll send you a database on that so you can select some of them. And this is true for CEO searches, for any type of searches in the healthcare industry. And I'll also send you that link that I was talking about to some of you. The state of Alabama, their state planning agency has a map of the United States. And there are about, I think it's 26 states that still have certificate of need, mainly in the Northeast, the Mid-Atlantic, the Southeast, and the Midwest, which means you have to get prior approval from a government agency before you can bill something. But they're very different. For example, in Florida, you need a certificate of need for a hospital but not for an ambulatory surgery center. For Nevada, you need a certificate of need for rural areas, which nobody's going to go build anything in anyway, but you don't need it for Clark County, Las Vegas, or for Reno, where they should have it. So they vary, and they also have dollar amounts. So that some of the things that Dr. Patel was talking about yesterday and that Lori was talking about, you come in under that dollar amount, you don't have to get it. Like you can build an imaging center in a lot of states, like in Alabama, and you can build it without getting a certificate of need because you come below that dollar threshold. So all you have to do is click on your state and it'll take you to the state planning agency and you can see what the certificate of need requirements are for the state you're in without going and hunting it and trying to figure it out. And when we get this afternoon, I'm going to start off with Dr. Nesbitt and talk about a survey that we did, and then I'm going to talk about different career paths that you can take other than being a CMO or going to work for a consulting firm. There are a lot of options that you can do other than that in case you're looking for that. We talk about different types of physician alignment, physician organizations. We talked some about, Georgia talked about, how Memorial Hermann employs doctors and they have a physician network, but there are all sorts of ways that you can align with the hospital short of being an employed physician. So we're gonna talk about that. First, we're gonna, because now, what am I doing wrong, Randy? You went away. Okay, no. Randy, because what's happening now, about 80%, 15 years ago, of physicians were in practices of 3 or less physicians. Now they're either employed or they're in big practices. And they're in big practices. This makes me go forward. Go into big practices because we're moving away from fee for service and we're moving to value-based purchasing. And in my presentation on Sunday, we talked about all the metrics that you have to capture. Well, that involves a lot of people and a lot of resources in terms of electronic medical records and everything to be able to capture that data, to be able to get those enhanced revenues. And if you're in a practice of 2 or 3 physicians, you don't have the ability, resource-wise, to capture that data. And that's why a lot of physicians are moving into the employment arena, not just new physicians coming out, but physicians who are in established practices. We, in Texas, like California, we have corporate practice of medicine, so hospitals can't directly employ physicians. Whereas in Alabama, Louisiana, they directly employ. But you can do it through a 501A foundation, a not-for-profit, that's certified by the Texas Board of Medical Examiners. And it just adds an extra step to it. But even in corporate practice of medicine, you can employ physicians. But some physicians go into that because they want to get away from the business side. And then they get in there and they see all the bureaucracy. And no longer can you make instant decisions. It takes months and months, and they're unhappy with it, or they don't want to be employees. So we've developed a lot of different models where you can have the resources, but you're not employed. This is a survey of hospitals. It was a national survey, 311 CEOs talking about the different models they use. And they did 2 things. They said, what are you doing now? What do you see yourself doing 5 years from now? So I want to just look at what that is. This is the models that they're currently using. And it's not saying that 100% of it are, but this is what they're using. 77% are using employment. 67% are using clinical integration, which we talked about on Sunday, and I'm going to talk a little bit about clinical integration and the history of it in this presentation. Patient-centered medical homes. These are primary care. This is how they're aligning with their primary care physicians, patient-centered medical homes. Risk-sharing arrangements. We talked a little bit about that on Sunday. Everything from full risk capitation to shared risk, the shared savings, the ACO model, all of that. And shared savings contracts on the Medicare side, where if shared savings, you have no downside risk. If you come in under budget, then you get a share of it. The physicians get it, the hospital gets it. Memorial Hermann, they've had the top ACO model on Medicare. They got like a couple of years ago, $80 million that they shared with their physicians on that. And that's upside risk only. Bundle payments is something that is very popular. I'm sure that you're aware that CMS did the total joints and the bundle pricing, and they started that during the Obama administration. When the Trump administration came in, on the Medicare side, they shut that down. But it's going great guns on the commercial side. The commercial side is very interested in that. We're seeing that growth in that area with that. That is, you're at risk. And we're going to talk a little bit about the bundle pricing and where you could be doing that. And then co-management. Co-management is where the physician forms a management company and they manage certain departments in the hospital. For example, the cardiology, or you could do it with outpatient surgery or do it with surgery. I had this little hospital client in Louisiana and they contacted me. They wanted to buy this general surgeon's practice. And they wanted to buy it because he had gone to this ambulatory surgery center. And this was a guy, he was their highest producer. And he was a very vocal leader person. And when he had gone to the ambulatory surgery center, he had taken a lot of the other surgeons with him. And this was a small hospital. And it had impacted them dramatically. And so I said, why do you want to buy his practice? And they said, because we want him to come back and do his surgeries here. And his big reason for going to the ASC was the OR was so horribly managed. That the scheduling was bad, the staff was bad, he hated everything about it. And I said, well, let's just do a co-management agreement with him. So we did, and he put together a company. We had an outside company come in and determine what the value of his services were. A hospital did some of them. They did the purchasing. They provided the employees, the hiring and all of that. He did the scheduling. He did the implants. He did certain things. And it can't overlap. That you had to definitely do it, and they had to definitely be separate. And then we had quality metrics for him. If he achieved certain things, he could basically double what he was making by doing it. Within a couple of years, he was out recruiting other surgeons to come there. He had not only brought his business back, but he had brought all these other surgeons in there. Everybody was happy. Everybody was making money. So it doesn't just have to be in your big hospital where you're letting them manage the cardiology department, or the orthopedics department or something like that. You can do it even in your smaller facilities. You can do a co-management agreement. And you just have to be very careful in how you structure it and in doing the evaluation of the services. Then, what our models are you going to begin to do? The first one was, what are you doing? This is what they say they're going to start doing. Risk-sharing agreements. We're seeing those more and more. With the ACOs, you start out with only upside risk, and then you go into full risk. And in a few minutes, we're going to talk about why people did ACOs. We're not seeing new ACOs created now because we're seeing the clinical integration model. Bundle payments. We're seeing more and more people go into the bundle payments. First driven by the Medicare, but now Medicare stopped it, and now we're seeing a lot in the commercial side of it. Shared savings contracts, they're got more and more doing that, and they're going from the government with the Medicare shared savings. We're seeing more and more commercial payers do that. Co-management, more doing that. Clinical integration and patient-centered medical homes. The reason the clinical integration, patient-centered medical homes are at the bottom is because so many people are already in them. And so these are people who are just picking it up. Okay. What are you doing with your primary cares? Clinical integration. You can't do clinical integration with a large base of primary care. Again, patient-centered medical homes is only primary care. ACOs, employment, they employ primary cares to get that referral base. Hospitals live on orthopedics and cardiology. but they got to get the patients. And I have orthopedic surgeons who've never done workers' comp in the past 10 years have gotten into workers' comp because their referrals have dried up because the hospitals bought the primary cares and they're steering them to orthopedic surgeons that they own. Shared savings, bundle payments, and then co-management. In the bundle payments, even if it's cardiology, within there, you've got the internal medicine. In that bundle payment, you've got the internal medicine doc, the anesthesiologist, the cardiologist, the cardiovascular surgeon. All of those are bundled into that, along with the facility payment for the hospital, all the ancillaries, all of the subacute, all of that is part of that bundle payment. What are you doing with your specialists? Clinical integration, bundle payments. The big areas there, again, are there's two types of bundle payments. You can bundle procedure-based bundling, which is mainly cardiology or cardiovascular and orthopedics. Then you've got the chronic diseases like cancer, where you bundle for a period of time. And it's not episodic care, but it is managing that patient over a period of time that you bundle that. ACOs, employment, shared savings, and co-management. Okay, well, I'm going to skip this because I've got it again. I duplicated the slides in here. Okay, ACOs. We started out with the Obamacare in March of 2010, came up with accountable care organizations to go into the shared risk on the Medicare side. And what happened was we had a lot of your large hospitals do it. And the reason that they did it was so that they could negotiate for both the physician component and the facility component. And the Federal Trade Commission, the FTC, says that unless you're sharing risk, unless you're at financial risk, or unless you're an ACO, or unless you're truly clinically integrated, you cannot negotiate for both the physicians and the hospital. It's antitrust, and they'll shut you down. Back in the early 2000s, there were about half a dozen physician networks. Memorial Hermann did it, GRIPA, Greater Rochester IPA, Advocate out of Chicago. They went to the FTC and they got approval for their hospital physician organization to be able to negotiate rates for both the physicians and for the facility. Then the FTC stopped doing that. They did those 6, they didn't do anymore. So the ACO, the Medicare ACO that came out in 2010, came in the legislation in 2010, was the only way that you as a hospital could come together with your physicians to negotiate rates. And you get higher rates because you have more market power if you're the hospital and the physicians. Most of the people, especially the large systems that went into the original Medicare ACOs, did it not for the Medicare business, but to use it as a contracting vehicle for commercial, because that's where the dollars are, on the commercial side. And that was the only organizational structure available to them to do it. But for an ACO, you had to be Medicare certified, which were a whole bunch more hoops to go through than clinical integration. But clinical integration at that time was not an option. And we had Dr. Fernandez, who had founded the Memorial Hermann Network. They were doing an ACO, and we had him come speak to this meeting. And I asked him, I said, are y'all really doing this, not for the Medicare patients, but for the commercial? And he hedged on it, but yeah, that's exactly what they were doing. Well, now that in 2013, February the 13th of 2013, the Norman, Oklahoma PHO, and I'm going to give you a link to it, said, the FTC said, if you're doing all the things you say you're doing, then yes, you can take risk. And so now we don't have to be an ACO. So the development of ACOs, except for some of your rural ACOs and things like that, stopped. And now everybody's developing clinically integrated networks because it's easier. And you can use it on the commercial side. And we know the attorney for the Norman, Oklahoma Clinically Integrated Network, the Norman, Oklahoma PHO, he was inundated with thousands of phone calls of how did you do this? And the FTC said, you can't cookie cutter it. You can't take everything they're doing, their policies and procedures, and do it. You've got to do your own. But we're seeing we have seen since 2013, a huge increase in the development of clinically integrated networks. And because now you have that option as opposed to the ACO. Okay, that said, you don't have to be an ACO. You can IPA, Independent Physician Association. An IPA that is not clinically integrated cannot negotiate rates for all the physicians. You can do a risk-sharing contract where you're at financial risk, or you can use the messenger model, which says you basically, the IPA negotiates the rates, and then they send it out to every physician. Are you going to opt into this contract or not at these rates? But if they're just an IPA with the physicians coming together into an organization, unless you're doing a risk contract, unless you're clinically integrated, you cannot negotiate rates for all the physicians. A PHO is just a physician hospital organization. It just brings the physicians and the hospitals under a single organization umbrella. And again, unless a PHO is like the one in Norman, Oklahoma, and is a clinically integrated network, you cannot negotiate rates for the physicians. You have to use the messenger model. But PHOs are becoming much more popular. They were very popular in the 90s when we first got into managed care. The reason for that is that the cost, the hospital absorbs more the cost of developing it and running it. And then the clinical integrated organizations or clinically integrated networks. They're used mainly for commercial and self-insured employers. They're generally formed around a hospital. If you have an IPA, I'm sure some of y'all are familiar with HealthSpring, the Medicare Advantage product, where you basically, once you become a Medicare Advantage patient, you join the HealthSpring or WellCare or any of the other ones, then you're no longer a Medicare patient, you are the HMO patient. The way the network works for HealthSpring is they have formed IPAs under the Renaissance umbrella, and those IPAs are formed around hospitals. Because as you as a physician, you're not going at risk with some doctors, a group of doctors 60 miles away in a hospital where you don't even know those people. You're going to do it. So they're formed in pods where they have the IPAs around the individual hospitals, and then the Renaissance or is the umbrella organization that manages, the management company that manages all of those, but the actual IPA is around specific hospitals that are participating in the health spring. And they have been highly, highly successful with that model and with managing the care for the Medicare patients. And when Dr. Patel was talking yesterday about how difficult it was for the freestanding ERs and for the micro hospitals to get CMS certified, and so they couldn't take Medicare patients. They can't take regular Medicare patients. They can take the Medicare Advantage patients. They can bill for the Medicare Advantage patient because they're no longer Medicare patients. They are the HMO patients. They are the insurance patients. So you can take those. They're a vehicle to do bundle pricing and shared risk contracting. They're your physician component for that. They have a legal structure that's separate from the hospital, and they use evidence-based protocols. And those protocols have to be designed by the physicians in that organization. You can start with the best practices from somewhere else, but you must have the committees and you must customize those to your specific location for your specific standards of practice in your community. They do managed care contracting, and they do fee-for-service contracting. There's still fee-for-service out there, especially with some of your smaller managed care companies. And so they do fee-for-service, they do bundle pricing, they do shared risk. They do the whole gamut of available contracting options, payment options. Then, as you well know, you're not just interested in the top line, the revenue, you're interested in the net income. So you're interested in reducing your cost. So they do group purchasing of medical supplies and office supplies, group purchasing of health and malpractice insurance. Rocky's going to talk later today. I used to do IPAs in Texas, and we got group purchasing on malpractice. That's not a big deal in Texas anymore because we have tort reform. For most of you in other states, that's a big deal, the value of it. And you can get some good discounts because you're marketing to the whole group of physicians, not just individually, and because you have credentialing standards, and you have the evidence-based protocols. Equipment, they do financial services, they do CPA services, they do health benefits, all of that. I had one IPA where we even had discounts with car dealerships and with travel agencies and with hotels, because what we did every year was a survey listing everything out and what are your top 5, and we would do those 5, and then the next year it kept going down to where we had discounted services with everything you can imagine, had a group purchasing agreements with them because we'd run out of things that we could do. Other models that you can use that we're seeing out there where you can negotiate rates, a group practice without walls. This is a model where you come into a group practice. Generally, you take existing practices and you put them into a single organization. Those physicians stay where they were. There's one in Jacksonville, Florida that was started by one of the PEMBA graduate in one of the first classes we had. And they went around and took existing OB-GYN practices in Jacksonville, Florida, put them into a group practice without walls. The doctors stayed where they were. If they owned the medical office building, they leased it to the group practice. But they were at financial risk because they were into a group practice. This came about in the Balanced Budget Act of, I think, 1993, when Clinton was president. For the first time, they defined what a group practice was. And the group practice was that 85% of your revenue came through a single tax ID number. And that's all it had to be. So the employees, you kept your own employees, but they were now employees of the group practice as opposed to the individual practice. One of the most successful ones is Fondren Orthopedics in Houston. They have a citywide network. They even own a hospital with HCA. And they took existing practices and put them together. Most of your group practices without walls are single specialty. And the reason they're single specialty is for the ancillaries, where you have the same ancillaries that you can do, for example, with orthopedics, owning a surgical hospital, an ambulatory surgery center, imaging center, because you can direct the patients to it. And so with a common interest, they're generally single specialty group practices without walls. Then a true group practice where everybody moves in together. No, that's Mayo Clinic, that's Ochsner, that's those big group practices. And then a management service organization where you just have a management company that comes in and manages all those practices, and the MSO basically provides the management expertise. They provide all the group practicing, and they actually hold the managed care contracts. PHO. On the PHO, you're going to have physician leadership, a commitment to quality, and a very robust data support system. Okay, here's clinical integration. This is the opinion, the February 13, 2013. And basically, this PHO had been in existence for a long time. They were using the messenger model. They became clinically integrated. For the clinical integration, they had electronic medical record system and interface. This is one of the big things that doctors complain about it. We usually have Scott Finn, who was with Memorial Hermann, then with the Baptist system in Birmingham. Now he's with Infirmity in Mobile. He puts together these clinically integrated organizations, and one of their biggest hurdles is training the doctors and getting them to use the system. Basically, you're talking about Epic or you're talking about Cerner. And so everybody's on those, is on those systems. You have to be trained on them. The doctors want to get paid for going to training, want to get paid extra for doing it. The hospital, you argue about that. That's one of their big hurdles. You have physician committees, and these have to be physician committees. And the quality assurance, a mentor committee, specialty advisory groups. Each different specialty comes up with the protocols that you're going to follow. Then you monitor to make sure they follow those protocols. If they don't follow the protocols, you have the mentoring committee that comes in and mentors them and say, here's the protocols, you need to do it. If they don't follow the protocols, you kick them out. The clinical practice guidelines, that's what they're following, the protocols. The physicians have to be involved. It can't be an exclusive arrangement, and limited anti-competitive spillover effects. One of the things the FTC said, with how they gauge physician involvement, if we come in and we interview the rank and file physicians, not the committee chairs, not the physician leadership, but the rank and file physicians about how this runs, are they going to be able to tell us? So it can't be just lip service to the doctors or on these committees, but they don't really do anything, and the hospital does everything. And they must operate as proposed, and the FTC will continually monitor it. You don't do it once and set it up and then go off and change how you actually operate. They come back and continuously monitor it. And you have to have the continuing counseling and training from the FTC. Okay. As I said before, you don't have to be a PHO. You can be a clinically integrated organization, and that's what everybody is. This is the due diligence checklist what the FTC looks at. Do the physicians plan to do, what do they plan to do together in a clinical standpoint? How do the physicians expect to accomplish their goals? What basis is there to think that the individual physicians will actually attempt to do this? It's not just something you set up and put on the shelf and never truly implement. What results can reasonably be expected, and how does the joint contracting with payers contribute to accomplishing their goals? Those are the questions when they come back and continuously monitor that they're going to ask. And here is a website where you can go and read the FTC opinion on that. This was a landmark case. When I got in one of my listservs this, I started calling my healthcare attorneys and asking, does this mean what I think it means? Because it was revolutionary to how you're going to operate. And every one of them said, it means exactly what you think it's going to mean. Okay, other issues. I want to say one quick thing I've told some of y'all in the breaks and things. I have a consulting group of individual consultants that we meet once a month and just talk about issues, and we cross-refer, but we have a symposium once a year. And what we do is we bring in employers, because employers are really the ones driving the change in healthcare. It's not the government, because the government can't agree on anything. And they're going out there and doing innovative things. And in our symposium, we invite employers, top employers who are doing innovative things, to come and talk about what they're doing today and what they're doing in the future, so that physicians can get ahead of the curve and can begin to participate and begin to do things. And I talked about the city of Houston with their wellness and prevention program. That was one of the things. We go to the managed care companies, and managed care companies have two sides, and they're silos, basically. One that y'all deal with, which are the contractors, the provider relations, all of that. The other side is the sales side. And the sales side is where they go out to the employer groups and sell their services. And we go to the sales side and we say, what are your employer groups asking for? And they want to keep their healthcare costs down, but they're also concerned about the time off work that their employees take to access the healthcare system. And feedback we're getting, we want mobile mammography that will come, or mobile imaging that will come to our campus, so our employees don't have to go to get those services. So we got a radiology company that went out there and did that. Health screening. Primary care practices, the nurse practitioners go out there and do health screening, early identification of diabetes, hypertension, all of those things. One of the alums from this program, from that 2010 class, when we were here when they passed Obamacare, lives in Houston. Stephanie has a weight loss clinic. She goes on site to these employers. You identify the obesity, you identify diabetes risk. She goes out there with her weight loss clinic so those people don't have to take off work to go weekly to those weight loss clinics. We've even put radiation oncology where we had a large cluster of large employees. They didn't want their employees having to take off half a day every day for 6 weeks to go to the MD Anderson to get the radiation. We put it out in Baytown where you could go on your lunch hour. So it's not just the cost of healthcare, it is the access and getting it. One of the speakers mentioned having the medical services on campus, have a company doctor where you can go see them. It's all sorts of things so that you go, rather than sitting in your ivory tower and saying, okay, what programs can we do? What do we think they want? You physically go and ask them. And then you give them, what do you want? Oh yeah, I can do that. And you go do it. The issues we had, Dr. Patel talked about freestanding ERs versus urgent care clinics. Urgent care clinics are really just a physician office with extended hours. And for that, you get reimbursed about 125% of what you would get reimbursed at the primary care office for an 8 to 5 office. For access, you're getting that extra 25%. And they do not get a facility fee. A freestanding ER, and the reason that people do that is because you can charge a facility fee. So you bill for the professional component and the facility fee. That's why they're so much more expensive. So you've got those retail clinics that are in the Walgreens and the CVS. You've got the urgent care centers that are generally freestanding and that have some of them 24/7 access, some of them just extended hours that are in the strip malls and that type of thing. And then you've got the freestanding ER, which are more expensive. There's a lot of pushback on the freestanding ERs because the average income of the area where most freestanding ERs are $90,000. They're not in the inner city where you really need the access, and they cost so much more. You should be going to an urgent care clinic to get a script written for colds, for minor things, and then the emergency. One of the issues with a freestanding ER also, if you go there and you have a coronary, you have something you need to get transferred to a hospital, the ambulance, they don't pay for the ambulance. You're going to have to get yourself there. Most of them have agreements with ambulance companies that would transport you at a discounted fee. But
government insurance, I just want to interject, government insurance like Medicare will pay.
Yeah, Medicare will pay, but commercially, but these people, they don't take Medicare in those freestanding ERs.
That's privately owned.
Yeah.
Texas is not like most of the country that have the hospital owned.
Yeah.
Freestanding completely.
Yeah. Medicare pays for the transportation, but commercial doesn't. So that's an issue that you run into. That's a minor issue compared to the cost differential. A lot of people think they're going to urgent care clinic and they go to a freestanding ER and they get a tremendous bill.
And I just wanted to piggyback on this point because I am associate director for freestanding with UAB.
Mm-hmm.
But you need a certificate of need in Alabama, and you have to be tied to a hospital setting. So kind of all those regulations are the same. That they,
if you're
UAB.
Yeah.
And one of the, I guess, I don't know if it's innovative, but one of the things that UAB does that, it feeds into their system. So if you need to be admitted or placed on observation, we actually contract with a EMS group. And they keep a van at the site anytime we need to transfer. If you go to UAB, we pay for it.
That's why I said you need an arrangement with them, either a discount or where you're transferring them to your hospital.
Now, if they go somewhere else, they have to pay for it.
Yes.
This freestanding ER and micro hospitals that we were talking about, the commercial insurance is not Medicare patient.
Yeah, they're predominant. If they're freestanding, they're mainly
When a
commercial.
patient walks in there and if you refuse, how is it going to
They
violation?
Well, they don't. If they're not part of a hospital, they're not subject to MTAL. But they're not going to turn them away, so they just don't bill them. But if they are a Medicare Advantage patient, then they can bill them.
So even if they are micro hospital, the regulations apply like a hospital, but they don't violate health.
If they're a micro hospital, they would have EMTALA. If they're a freestanding ER affiliated with a hospital, they would be subject to EMTALA. Okay. HOPD, Lori talked about that. And again, HOPDs are pretty well done for the Medicare, Medicaid side, but again, the model that she discussed, they never did Medicare, Medicaid anyway. Medicaid pays horribly for ASCs and for outpatient. And so you don't have those. They're focused toward the commercial payers. And on the micro hospitals, basically that sprung out of the freestanding ERs wanting to be affiliated with the hospital so they could get that step up in reimbursement. And then they overbuilt them. At one point in time, we had 45 freestanding ERs in Houston. We could support about 15. So they started becoming micro hospitals so then they could get that step up in reimbursement. Domestic medical tourism. This is where a lot of your bundle pricing comes in. Companies like Walmart, like Shell, like Ford, what they do is they send their patients, you select a certain insurance product that they have, which has a lower premium, then they send you to a specific location for heart surgery, for orthopedics. And with Walmart, they have a number of them throughout the country, goes out for bids. In our region, they're using Scott and White for the heart and for the orthopedics. Shell Oil, they use cardiovascular care providers. Denton Cooley's, the group he originally founded in Houston. Their bundle pricing is with St. Luke's, although not anymore. St. Luke's been decertified by CMS because of all their people they killed and because of their incompetence and no, giving the wrong blood transfusion people. I mean, they lost CMS certification. I mean, it's really bad. They're on the front page of the Houston Chronicle at least once a week with somebody else that they had a horrible outcome. But they use Methodist Hospital and the St. Luke's for their bundle pricing. And you just package everything together. As I said, the doctors, the primary care, the specialists, the anesthesiologist, all of that, the facility, all the ancillaries, and then the post-acute care. And you have one price. And then within that one price, what you do is you have this includes X number of days in the hospital, includes the post-acute, includes all of that. And then if you have something that goes wrong, some complication or comorbidity with the patient, then you get paid on a daily rate for that. And so because you've got to protect yourself. One of the issues is making sure the doctors don't bill around, but you have to have a separate entity. It's for the Denton Cooley's group, it's cardiovascular care providers. They hold the contract with the managed care organization, in this case with Shell Oil because they're self-insured. The bundle payment goes to them, then they divvy it up and pay all the people. And they have contracts with all the providers as to what they're going to pay them for that. On the commercial side, the United Healthcare is doing that a lot on the East Coast. They're getting heavily into it. Now we're seeing ambulatory surgery centers get into it because you can do total joints within that. They're sending Johns Hopkins has a big program. People come from all over the country. They're not doing it just on price. They're doing it on the outcomes. You have better outcomes if the economic theory of comparative advantage, which you learned in your econ class. And the more you do, the better you are at it. And so you get better outcomes. And so this is a really big thing, and we're seeing more and more people go into it. And that's the domestic medical tourism. Everybody's familiar with medical tourism, where you go to India or Eastern Europe or to Mexico and have it done. Out of network, what we're seeing are EPOs, exclusive provider organizations, or what we call narrow networks. So you will lose patients because they can't go, they have no coverage if they don't go to this specific network. You've got to have something like a clinically integrated organization, all of the pieces in there so that you can offer that. We're seeing them with out-of-network fee schedules. If you're out-of-network, then you pay on charges. But we're seeing now in the self-insured, they can do it because they're under Untitled. They'll say, okay, if you're out of network, I'm not going to pay you a percent of charges. I'm going to pay you a percent of the out of network fee schedule. So if you're in network, you're getting 125% of Medicare, and I'm paying 80%. Insurance company, I'm paying you 80%. If you're out of network, my out of network fee schedule is 100% of Medicare, and insurance company's only paying you 60% of it. That's what's driving everybody in network. They're either saying we have no out-of-network coverage, or if we do have out-of-network coverage, the payment's not tied to charges, it's tied to the out-of-network fee schedule, which is lower than we would contract with you for. They're requiring, we talked about this, hospital-based physicians to be contracted. We've already talked about that. And then they're reducing the payments to the hospital if their hospital-based physicians are out of network. We talked about that too. It's predominantly with anesthesiologists and with ER docs. The insurance exchange products, what they're telling us is that the non-payment of the premium, this is one of the things that the AMA was very concerned with to begin with. People would come in and pay the first month's premium, and then basically they can't kick you out for 90 days. So then they'd come back and retroactively deny payment because they paid the January premium and then they didn't pay ever again. But if you contacted them and said, this person in network in February, March, and April, they said yes. And so you treated the patient, and then they came back and said, oh no, they weren't in network, they retroactively denied. And what the exchange products are telling us is that it's just like any individual policy that they have, only 12 to 20% of the people do that, pay the first premium and don't pay anymore. And then you have the issue of the large deductibles. This is another thing that we're seeing is factoring of receivables, where you basically sell your receivables at a discount in order to get the money. They have some things where they basically will do it for individual doctors within an ASC environment. It's real tricky to get it right, and you've got to have it financial risk and arrange all of it. It's just a way to get money to the doctors. And basically what you say is, okay, doctor, you form a company, we'll sell our receivables to you, and then you can make the money on the discount. You'll sell the receivables at 70% of face value. You collect that 100% of that receivable, you just made 30% on it. What you can't do is you can't say, Dr. Jones, we're going to sell you your receivables. It has to be of the entire group. It has to be multiple physicians on there. You can't do that. But that's another way that they're trying to get more money to the physicians, by letting them make the money by factoring the receivables too. Okay. Anybody have questions? Okay, you need to be aware what you're seeing on this is it's a ever-changing landscape out there. And one of the exercises that I do with my graduate managed care classes, I give them a managed care contract to review with a checklist. Because most doctors just sign and they don't know what's in there. And then you come back and you say, oh, they change the fee schedule on you, they do something, they kick you out, and you can't do that. Well, yeah, you signed the contract and contractually you can. You need to, most people focus on the rates you're getting paid, but the contract language and what they're doing is just as important as what you're getting paid. Because you can have a great fee schedule, but if they can unilaterally amend that contract, 30 days later, you can have a terrible fee schedule because they unilaterally amended that contract.